A very good morning, Emeritus Honorable Chairperson Sir Dr. M.L. Swankar, Vice Chancellor Dr. Achal Gulati Sir, Chief Advisor to Chairman and our former Vice Chancellor Dr. Sudhir Sazev Sir, Medical Director Dr. Jaiswal Sir, distinguished faculty members and students. It is always an honor to present our department in front of this August gathering. The department was established in 2017 with a vision to provide excellent medical care and critical care to our fellow patients. At this time, we are looking after 8 ICUs, 98 beds, and in very near future, we are going to add more beds to our department. The daily workload is about 80%. This is the team critical care, the 10 very accomplished consultants from anesthesiology and pulmonary medicine, and I would like to welcome at this moment Dr. Subhash Chandra, who is the DRNB critical care, joining very recently, Dr. Subhash, and Dr. Sangeeta, senior consultant critical care medicine as well, to our team. I am very much thankful for the management MGUMST for providing world-class infrastructure and ultra-modern equipment. So far we have done more than 250 CRRT sessions and 25 ECMO sessions. And coming to quality indicators, which is a very integral part of critical care, if you see, this is the standardized mortality rate, which is coming 0.33 cumulatively for last 6 months. In those 6 months, total ICU admissions were more than 2,300. And despite of this, the SMR is 0.33. Ideally, it should be less than 1, which is the international standard. As far as hospital infection control or hospital-acquired infection are concerned, the CLABSI, COTIN, VAPRIT, these 3 rates are also according to and in line with our MGUMST internal audit, the minimum requirement. As far as academics are concerned, DM critical course was commenced in 2021. Till date, 3 sessions and 3 batches have already joined. This year also 3 students have joined, and still the counseling is going on, so I am hoping that the 4th candidate will join very soon. Apart from this, we are having 1-year diploma course in critical care medicine, and regularly we are having students for this diploma course as well. Our student has won several prizes. Dr. Sankalp has won the first prize in the poster presentation in the World Congress of Comprehensive Critical Care, and Dr. Nidhi is to 3rd prize in the oral paper presentation during the Raj Criticon 2024. So far, we have published more than 49 papers in PubMed Index, Scopus Index, and various other index journals. Some of them are highlighted here, and the cumulative citations of across the whole department is 2,900, with that is an X of 11. There are 11 ongoing research in our department, and we have MOU with 2 teams. One is ICMR and the CDC, and second is with AIIMS Jaipur. We are also part of 4 multicentric trials. These are the Impact, Impress, National, and CDC trials. Very recently, Dr. Shashti has represented Mahatma Gandhi University of Medical Science and Technology at Shanghai, China during the Sino-Indian Anesthesia Forum. And I will be representing MGUMST during Donorate 25, which is a organ transplant and art conference, international conference, 4th edition, which is being held on 6th October, Messina, Italy. So far, we have published 13 chapters cumulatively, and 5 chapters are under press that will be published by February 2026. We are regular participation in Jaipur Swasthya Charcha. We are regularly conducting POCUS, that is point of care ultrasonography workshop, and ECMO and CRRT workshop for a few years now. And as far as other services are concerned, we are providing code blue services to Annex building and SRCC building along with critical care outreach team. This is the number. It is provided to each ward. If you have any patient who is deteriorating, you just call on this number and we will reach you in your ward or in your room. We are involved in training of our PGs in the induction program. Sure, sir. सर वैसे दिया हुआ है सब जगह सारे वार्ड में, but we will. जी sir, sure. And we are into the induction program for PG as well as nursing, and we are also training for IV cannulations and airway for our PG students. We are also the active faculty for ACLS, BLS, ATCN, and ATLS courses, and so far more than 5 1,000 participants, including the mass training programs, have been trained by our department in over 5 or 6 years. And we have been awarded for our services. Very recently, in month of January, we were awarded by AHPI for excellent in critical care medicine, and we are awarded, some of our faculty members awarded on this Independence Day by Honorable Emeritus Chairperson and Dr. Sonawala for the excellence performance during the JCI. We are always committed to provide excellent critical care to our patient, and with this I invite Dr. Ayush Gupta for the case.
Good morning, Honorable Emeritus Chairperson Sir, respected Vice Chancellor Sir, senior faculty and my dear colleagues. Myself Dr. Ayush Gupta, a second year DM critical care resident. I will be presenting today's CCR under the guidance of Dr. Ashish Jain Sir, our head of the department, and Dr. Puneet Pawar Sir, assistant professor in our department. So moving forward with the case history. This is a case of a 29-year-old female, para 1, live 1, who is on the second postpartum day following a lower segment cesarean section, presented to the emergency department with a complaint of altered sensorium, decreased unit output last 12 hours, and shortness of breath for last 3 hours. My patient underwent a full-term pregnancy with an uneventful antenatal period, had an emergency LSCS on 19th of July. LSCS was an uneventful procedure and patient was stable for the next 12 hours post-operatively. She developed alternation of GCS of 14/15, hypotension with the mean arterial pressure of 60 mm of mercury, decreased urine output of approximately 300 ml in last 12 hours, and acute onset of shortness of breath of MMRC, grade 4, 12 hours post-LSCS. Her pre-op investigations were normal, and post-operatively, which were conducted 12 hours post-LSCS, show leukocytosis, thrombocytopenia with raised INR, RFT and LFT were deranged, along with deranged coagulation profile and raised inflammatory markers. She was managed initially just after the LSCS with injection ceftriaxone, amikacin and metronidazole, later switched to piperacillin tazobactam after patient developed complication. Along with, she was resuscitated with 4 liters of normal saline and ringalectid for hypotension. She was also given 4 units of fresh frozen plasma and RDP for correction of coagulopathy. Vasopressor support is started. Patient developed shortness of breath and supplemental oxygen applied, and she was referred to Mahatma Gandhi. There was no significant past personal medication, family or allergy history. She is vegetarian with normal sleep pattern, bladder and bowel habits. She denies history of smoking, alcohol or substance abuse. So this is a pictorial timeline depicting the clinical course of the patient. So as you can see, at 0 hours, she underwent an emergency section which was uneventful. She remained stable until 12 hours of post-LSCS. Post 12 hours, she developed hypotension, altered sensorium and reduced urine output, for which she received 4 liters of crystalloids with escalation of antibiotics. Simultaneously, she developed thrombocytopenia with coagulopathy, which was managed with transfusion of 4 units of FFP and 4 units of RDP. She also developed acute shortness of breath, was referred to Mahatma Gandhi for further management. On admission, on general examination, the patient was confused, pallor and icterus was noted. There was no cyanosis and JVP was not raised. Pitting edema was present over the back and lower limb at the time of admission. Following vitals were recorded. Patient had tachycardia with heart rate of 130 beats per minute. The pulse was low. Respiratory rate was 36 breaths per minute, was of abdominothoracic type with a saturation of 92% with supplemental oxygen of 10 liters per minute via face mask. She was afebrile. Her blood pressure was 95/64 mm of mercury on NORAD support of 0.1 microgram per kg per minute. Her urine output was previously stated as, and her urine was dark in color. Pain assessment was done through a critical care pain observation tool, that is a CPOT score, which came out to be 2/10, suggestive of mild discomfort. Her Q-SOFA score was 3/3, which is suggestive of need for ICU admission. Now the systemic examination. So central nervous system examination revealed the patient was confused with no focal neurological deficit. Respiratory system examination revealed tachypnea with respiratory rate of 36 breaths per minute and the use of accessory muscle for respiration. On auscultation, bilateral chords crepitation were heard across all lung field. Cardiovascular system examination, however, revealed no abnormal findings. On abdominal examination, there is a phalansteal incision with a clean and a dry dressing. The abdomen was noted to be distended. Auscultation revealed sluggish bowel sounds. On palpation, there was mild tenderness localized to the incision site without any associated guarding or rigidity. On genitourinary examination, a Foley's catheter was noted in situ, draining into a uro bag which contained dark colored urine. Sir, ECG shows sinus tachycardia and rest was normal. So we have done on admission, SOFA score was done, which was resulting in a score of 15. The score is indicative of severe organ dysfunction and correlate with a high risk of mortality. So to summarize, we have a case of para 1 live 1 female on a post-operative day 2 following emergency lower segment cesarean section who developed hypotension, altered sensorium and decreased urine output post-operatively. She was initially resuscitated with crystalloid blood products, but she subsequently required vasopressor support and was referred to our center with shortness of breath. On admission, her vitals showed tachycardia with a heart rate of 130 beats per minute, hypotension with blood pressure of 94/60 with noradrenaline support, tachypnea with a respiratory rate of 36 per minute and oxygen saturation of 94% on 10 liters of oxygen. General examination revealed pallor, icterus and anasarca, and systemic examination revealed respiratory distress, bilateral coarse capitation and oliguria. Key laboratory investigation suggestive of thrombocytopenia, AKI, hyperbilirubinemia, coagulopathy and raised inflammatory markers. After summarizing the case, I would like to ask the audience what can be the possibilities. And the initial management was guided by ABCDE approach. The patient airway was patent and her breathing was supported with non-invasive ventilation with PEEP of 6 cm of water and a pressure support of 12 cm of water and FiO2 of 40%, targeting saturation of 94% while minimizing the work of breathing. Hemodynamic support was provided with noradrenaline infusion of 0.1 microgram per kg, titrated to maintain the mean arterial pressure of more than 65. Serial neurological assessment including Glasgow Coma Scale, orientation and evaluation for delirium or encephalopathy was performed. Comprehensive ICU care bundle was followed and empirical antibiotic was started including meropenem, teicoplanin and metronidazole was initiated. Now we are in a dilemma to give fluid or diuretics in a patient with septicemia.
So can I ask you, how did you get to this empirical antibiotic combination? Is this as per the antibiogram of the ICU? This is the first line.
Yes, sir.
For all patients who come with suspected severe sepsis.
Sir, patient already have taken was shifted on piperacillin tazobactam, but her condition was deteriorating. So she was already previously hospitalized. So that's why we started a broad spectrum antibiotics, that is meropenem. Yes, sir. Yes, sir. She was in metronidazole, sir. So meropenem we have started.
So do you have a set protocol? Like in my department for neutropenic infection, we have a set first line. And if there is a culture positivity, of course it is changed, or if there is no response or deterioration in 48 hours, then it is changed. Do you have a protocol for antibiotics as per hospital antibiogram? So because that is available to us every quarterly.
May I answer? Sir, as per our hospital antibiogram, this patient comes in class 4 category of the patient. Patient is having MODS with deteriorating clinical features with shock and MODS. So we should hit hard as soon as the patient reaches to us. So we don't know the organism, likely peripheral sepsis. It could be resistant organisms. So we started with higher end of antibiotic, send the cultures, we de-escalate once the cultures we receive. This is the usual protocol, sir.
I think in postpartum DIC cases or ARDS cases, it is necessary to give antibiotics as strong as possible. That is rule of thumb.
To rule out this dilemma, we did point of care ultrasound. Sir, so the focus lung was done. We found a diffuse multiple B lines with smooth pleura, and the for IVC assessment for the fluid was status was done. It was distended more than 2.2 centimeter with no respiratory variation, suggestive of fluid overload. This is a 4-chamber of heart showing normal ejection fraction of 60% with dilated IVC and with no evidence of pericardial effusion or diastolic dysfunction. With the above clinical presentation, this cardiac panel is also suggestive of fluid overload. So after doing the point of care ultrasonography, we can rule out few of our possibilities. For a postpartum cardiomyopathy patient, the EF should be less than 45%, but in our patient, the EF is more than 60% and there are no signs of heart failure or raised GVP. For transfusion related acute lung injury, it should have a Shred sign and a bilateral pulmonary infiltrates on the focused lung, which was not the case in our patient, so ruling out the diagnosis of TRALI. And so since our patient was hypotensive with no raised JVP and no signs of LV dysfunction, this ruling out the diagnosis of transfusion associated circulatory overload. With the use of focus, we have ruled out the 3 major probable possibilities. After ruling out the possibilities of transfusion-related acute lung injury, postpartum cardiomyopathy and transfusion-associated circulatory overload, the remaining differential diagnoses are left are puerperal sepsis, amniotic fluid embolism, HELP syndrome and postpartum thrombotic microangiopathy. The initial management was continued, and through the focus we came to the conclusion that patient is in the fluid overload, so we started her on injection furosemide 20 mg stat, followed by 5 mg per hour infusion with strict input-output charting. On day 1, investigation report arrived suggestive of leukocytosis, thrombocytopenia, worsening azotemia and deranged liver function test, and markedly raised LDH suggestive of hemolysis. 2 sets of paired blood culture were sent, along with which we also sent urine culture and microscopy. Urine microscopy was full field with RBC. USG whole abdomen showed hepatomegaly, bilateral pleural effusion and moderate ascites, and X-ray suggestive of bilateral pulmonary edema with minimal pleural effusion with apparent cardiomegaly. Now I would like to call Dr. Simran, Department of Obstetrics and Gynecology, to take this case further.
Thank you, Dr. Ayush. Good morning, respected teachers and my dear colleagues. I am Dr. Simran Singh, a second-year postgraduate resident in the Department of Obstetrics and Gynecology, and I'll be presenting a case of postpartum female with acute respiratory distress and coagulopathy under the guidance of Dr. Swati Garg and Dr. Kalpana Tiwari. So my patient was a primary gravida with 39 weeks period of gestation, was spontaneously conceived. Her entire antenatal history was uneventful with no history of gestational hypertension, diabetes, hypothyroidism, asthma or any other chronic illness. Induction of labor was done by tablet misoprostol 25 mcg, which was followed by artificial rupture of membranes. Lower segment cesarean section was done in view of failure of induction. The timeline from induction to cesarean section was 5 hours. The cesarean section was uneventful and there was no history of excessive blood loss. The patient was asymptomatic for 12 hours post LSCS, after which on postpartum day 2 she developed difficulty in breathing, dizziness, decreased urine output and mild confusion. As discussed earlier by the critical care team, on presentation, the general condition of the patient was fair. She was afebrile. She was slightly disoriented but obeying commands. Her pulse was 120 beats per minute. Her respiratory rate was 36 beats per minute, and her BP was blood pressure was 120 by 70 on noradrenaline infusion, and her on per abdomen examination, soft gaseous distension was present with presence of no guarding and rigidity. Uterus was palpable to approximately 20 weeks size, was well contracted and mild tenderness could be seen, which was normal for postpartum day 2 status. Bowel sounds were sluggish. Caesarean scar was healthy. Dressing was dry with no discharge or induration. On pervaginal examination, lochia was healthy and non-foul smelling. Bilateral breasts were soft with normal changes of pregnancy and no engorgement was seen. So by looking at the condition of the patient and the laboratory reports, we come across two differentials. First being the HELP syndrome and second being amniotic fluid embolism. So normally the HELP syndrome is a syndrome which stands for hemolysis, elevated liver enzymes and low platelet counts. Patient will be having a history of gestational hypertension and proteinuria. But in this case, the patient did not have any previous history of gestational hypertension and proteinuria was absent in this case. So, a presentation of atypical HELP syndrome can also be considered. Normally, 80 to 85% of patients will present with HELP syndrome, and of that, 10 to 15% will present with a condition known as atypical HELP syndrome. And second being amniotic fluid embolism, in which there is a sudden onset cardiorespiratory collapse during labor. There can be pulmonary hypotension, and patient can present with headache or hypoxia. But in this case, amniotic fluid embolism is very less likely, as there are very rare cases in which there is delayed presentation of amniotic fluid embolism, while in cases of HELP syndrome, it can present usually within 48 hours postpartum or can appear up to 7 days postpartum. So there was no history of PIH, and because there was no sudden onset cardiorespiratory collapse during labor and no pulmonary hypertension, so we would like to rule out amniotic fluid embolism as a diagnosis in this case. So possibilities after looking at all the lab reports, we have ruled out amniotic fluid embolism and atypical HELP syndrome. We are left with two possibilities: purpural sepsis with multi-organ dysfunction with fluid DIC AKI with fluid overload, and postpartum thrombotic microangiopathy. We keeping the differentials of atypical HELP syndrome and amniotic fluid embolism. Still, to rule out any evidence of sepsis, we ordered a USG whole abdomen pelvis. USG showed moderate ascites. Uterus was normal postpartum. There was no evidence of retained products of conception. As the patient is day 2 post-operative, intra-abdominal mild ascites is acceptable. We kept the patient on abdominal girth charting and followed up in successive scan. On follow-up, patient remained hemodynamically stable. Hemodynamically stable. It meant that there was no evidence of ongoing hemorrhage. The abdominal girth also decreased on follow-up, and on follow-up scan the ascites also reduced. So keeping sepsis in mind, we also ordered a high vaginal swab, which came out to be negative for any growth. This was our follow-up, and because of the patient had deranged liver function tests and kidney function tests, we ordered a hematology and nephrology consultation. And I would like to call upon Dr. Vaishali, clinical hematology, to continue further.
Thank you, Simran. A very good morning to respected faculty, seniors and colleagues. So, a 29-year-old female, day 2 post-emergency LSCS, was referred in view of thrombocytopenia, leukocytosis, raised INR, which is associated with azotemia and hyperbilirubinemia. So, there was neutrophilic leukocytosis, thrombocytopenia, azotemia, direct hyperbil more than indirect, and elevated PT and elevated LDH. Peripheral blood film was suggestive of fragmented RBCs, that is schistocytes, neutrophilic leukocytosis and thrombocytopenia. D-dimer level was increased, serum fibrinogen was decreased, PT-INR was raised, and there was also a raised LDH level. So, microangiopathic hemolytic anemia with thrombocytopenia and deranged coagulation. These are two predictive scores. One is the International Society of Thrombosis and Homeostasis for DIC and plasmic score for TTP. These are predictive scores, and for DIC the score was 7, which indicates over DIC, and the plasmic score for TTP was 5, which indicates intermediate risk for TTP. So our possibilities could be DIC, since coagulopathy was deranged, thrombotic microangiopathy, and atypical HELP. We requested for a thromboelastogram so as to see the global coagulation profile, which was suggestive of a global coagulopathy. The R time and K time were raised, angle was decreased, and maximum amplitude was also decreased. So, if we look at the differential diagnosis favoring our case, there are several common features which include thrombocytopenia and microangiopathic hemolytic anemia. Since there is coagulopathy, it favors towards DIC. Since there is overt liver dysfunction, it favors HELP syndrome. Since there is overt renal dysfunction, HUS is also likely. And since CNS involvement was there, TTP is also a differential diagnosis.
यहाँ हमेशा ये ध्यान रखो कि pregnancy is a hypercoagulative state normally, physiologically. In spite of everything normal, first possibility should be DIC in pregnancy or after pregnancy, like in the postpartum period, because in pregnancy the coagulation profile goes high. All right.
So we advise to continue the management for sepsis, monitor for bleeding, monitor CBC and coagulation daily, transfuse platelets or FFP in case of bleeding, else avoid transfusions, and 6-unit cryoprecipitate transfusion. Now I would like to invite Dr. Ayush to take the case further.
Thank you, Dr. Vaishali. So moving forward with our case, on day 2 of admission, patient showed improvement in the level of consciousness, reflecting a significant improvement in the neurological improvement. Hemodynamics have stabilized and vasopressor support has been successfully discontinued. She continued to require intermittent non-invasive ventilatory support, improving PaO2 by FiO2 ratio from 100 to 300 and urine output has improved following diuretic therapy, and importantly her SOFA score has also shown significant improvement, decreasing from 15 at admission to 9 currently. But there are certain issues which are pending, such as respiratory distress requiring intermittent NIV support, bilateral pleural effusion, right side is more than left, anasarca, falling hemoglobin trend, rising total leukocyte count, worsening azotemia and persistent coagulopathy and deranged liver function test. So in the management, we stopped the vasopressors and reduced the diuretic dose to 20 mg 12 hourly and continued the same supportive care. Now I would like to call Dr. Vaibhav from the Department of Nephrology to take this case further.
Good morning everyone. Our team was called for the reference in view of decreased urine output, progressive rise in urea and creatinine levels. On examination, the patient was well oriented and obeying command. The vitals were comparatively normal. On auscultation, bilateral basal crepitations were heard and pedal edema was present. Lab reports were suggestive of deranged renal functions, liver functions, anemia as well as coagulopathy. So from our point of view, the possible causes of AKI in postpartum period could be HELP syndrome, atypical HUS and TTP, out of which HELP syndrome has already been discussed and ruled out, and both other causes, that is atypical HUS, TTPs, have features of hemolysis, thrombocytopenia, raised liver enzymes and renal involvement, which I have already shown in the slide. Thus, on the basis of our findings, following were advised from our side: giving an IV antibiotics, that is meropenem, teicoplanin and metronidazole according to creatinine clearance, continue the diuretic therapies, monitor intake and urine output strictly, avoid giving any further nephrotoxic drugs, and regular monitoring of renal functions, TLC counts and coagulation profile. Now I hand over to Dr. Ayush for further discussions.
Moving along with our case on day 3, our patient remained stable with improved urine output of 60 to 80 ml per hour with discontinuation of NIV support. Now our patient is maintaining saturation of 98% on 2 liters of oxygen via nasal prong. But the still pending issues are lab investigation suggestive of falling trend, worsening azotemia, persistent coagulopathy, chest X-ray findings suggestive of bilateral pleural effusion. In view of unresolved issue, the Department of Hematology and the Infectious Disease were called upon for the further evaluation and management. Now I hand over the case to Dr. Vaishali for the further discussion.
Thank you, Dr. Ayush. So, hematology review reference was given in view of a possibility of TMA and the need of plasma exchange. So, baseline coagulation and thromboelastogram favored DIC. Worsening azotemia with microangiopathic hemolytic anemia could be the impact of the baseline insult of DIC. If we consider TMA, that is thrombotic microangiopathy, HUS is more likely than TTP because there was more renal involvement in this case, and atypical help was still a possibility. So we advised for 1 unit SDP transfusion as the platelets were less than 20,000. Plasma exchange was not indicated at this point because it is only helpful in TTP, which was unlikely, and we advised to continue conservative management. Now I would like to invite Dr. Yash sir to take this case further.
Good morning, respected dignitaries and dear friends. So our department received reference on second day for suspected purpurial sepsis in this case. They wanted antibiotic optimization. The issues were worsening lab parameters and they wanted investigation advices. On our examination, patient was hemodynamically stable. The shock was recovered. History, general physical examination, systemic examination, the findings were matched with that of CCM team and we couldn't gather any new information. Surgical scar was healthy. There was no obvious focus of infection on examination in USG abdomen. But as depicted earlier, SOFA score raised by more than 15 points as compared to prepartum period and raised lactate levels. This was suggestive of sepsis. And like other departments, our DDs are also hanging between sepsis. Sir, for the definition of sepsis, we need like raise in SOFA score of more than 2. So it's a sequential organ function assessment. So if more than counts, more than inflammatory markers, if your organ dysfunctions are like successively deteriorating, it is suggestive of sepsis or ongoing severe inflammation. See here that most green ticks, that is most clinical features actually favored sepsis, while timing of onset, marked hepatic dysfunction, low blood pressure and absence of marked neurological features were not favoring other DDs. The only thing that was not adding up for the purpurial sepsis was the absence of fever in this case. So our most likely provisional diagnosis for purpurial sepsis, and most common pathogens that can be implicated for this condition can be Enterobacterus, group A Streptococci, Staphylococcus aureus, and since the onset was so dramatic, toxic shock syndrome due to both of these gram-positive organisms was also under consideration. Since it was a endometritis was in differential, so aerobic and anaerobic mixed infection was also considered, and the focus could have also been at other sites than that of endometrium. In this way, we advised investigation. We advised for the repeat blood culture, high vaginal aerobic and anaerobic swab cultures, throat swab aerobic culture, pleural fluid examination and culture, CT abdomen and pelvis. And since patient was already on antibiotic, we advised for DNA-based multiplex PCR for blood sample for common pyogenic organisms. At this time, ongoing antibiotics were injection meropenem 2 gram IV 8 hourly, metronidazole 500 mg IV 8 hourly, and teicoplanin 400 mg IV 24 hourly. We wanted to optimize this treatment and we considered following factors. Risk of MDR organisms. Since our patient was referred to us within less than 48 hours, the risk of broad spectrum carbapenem resistant Enterobacterus was very unlikely. Risk of anaerobic infection was very much in our case. We considered that. And since toxic shock syndrome was one of our differentials, so risk of exotoxinemia and targeting that particular pathogen was under our consideration. Ongoing empiric therapy and PK/PD parameters were also considered under the optimization. Since meropenem has already having going on in this case and has excellent coverage for anaerobic Enterobacterus and Streptococci, the need for metronidazole was not considered and we advised to stop metronidazole. And since already 2 to 3 days has been passed, the patient was on full dose of meropenem and teicoplanin, we advised to reduce the dose of meropenem 500 mg IVQ 12 hourly and teicoplanin 400 mg IV 48 hourly for the renal modification. To target the exotoxins in this case, we started injection clindamycin 900 mg IV 8 hourly, which is essentially an anti-protein antibiotic, anti-protein synthesis activity by targeting 23S ribosome of the bacteria. We advised for the review reference when the reports were to arrive. On review reference, sepsis panel was negative. All the cultures were also negative. Pleural fluid was transudative in nature and CT abdomen could not localize any collection. This is multiplex PCR syndromic panel for sepsis targeting most common pathogen responsibles like GNB, Staph aureus and Candida. And since it is based on DNA detection, it can be positive in cases with ongoing treatment also. Negative results from these tests gave us more assurance that these many pathogens are less likely the etiology when considered the overall clinical picture. So the current issues were TLC were persistently raised, RFT was worsening, urine output was improving, SOFA score was now 9. So this all shows that though labs were getting deteriorated, urine output and overall clinical features of the patient was improving. And since we couldn't identify the most common pathogens, and Staph aureus was again very much out of the picture right now, I will explain again later why, we advise to stop injection ticoplanin right now and continue injection meropenem and clindamycin in the same dose. We could have de-escalated to some lower antibiotics as suggested ampicillin or piperacin tazobactam, but as of now we didn't have any pathogen in our hand. Group A streptococci was also not isolated, but considering the definition, the possible toxic shock syndrome was still likely. I will explain it later on. Why streptococcal infection was less in the form of TSS was most likely? The triad of purpural sepsis, the fever, abdominal pain and tenderness and purulent discharge was not there. So obviously there was no endometritis in our case. And sir rightly explained that there can be hidden focuses like throat and skin, which could be the cause of toxic shock syndrome in these cases, because patient may be immunocompromised and de-desensitization actually reduce your inflammatory response in the cases. So there was normal USG, no signs of endometritis, and rapid onset of disease was pointing towards the exotoxin, that is superantigen sepsis. So if you want to differentiate between exotoxins and endotoxin, while endotoxin due to GNB are the most common cause of sepsis that are usually gradual in onset, because endotoxin needs to be presented by antigen presenting cells. While exotoxin is a superantigen, it directly stimulates your immune system so rapidly, causing the cytokine storm, and can lead to all these things. In these cases, starting anti-protein antibiotics like clindamycin and lysozyme often gives the dramatic results. And why it was not necessarily the staphylococcus? Because of the lack of fever and desquamation, which is the criteria for defining staphylococcal toxic shock syndrome. While streptococcal toxic shock syndrome requires hypotension and multiple organ dysfunction, which was there in our case, the only thing we were falling short of was isolation of group A streptococci in sterile or non-sterile places. This may be because of ongoing prior antibiotics. And these exotoxins like streptolysin O, S, exotoxin A, B, all can cause hemolysis, GIC, all the pictures which were present in our case. And most of the streptococcal infection are usually within 0 to 2 days of the presentation in postpartum period. And most of the cases which are presenting early do not have fever, almost 25% of the cases. These are the similar case reports as ours, and this excellent review on the 100 cases, in this review they depicted that in most of the cases they couldn't identify the focus of infection. So I would like to call Ayush Gupta for further discussion.
Moving forward with our case on day 4 to 6, our patient is hemodynamically stable, respiration and other parameters are within normal limits. Urine output has improved, but our concern was worsening azotemia, bicytopenia, leukocytosis and coagulopathy. Her hemoglobin has dropped down to 7.1 with platelet count of 56,000 and the creatinine rising up to 5.9. So we again called the nephrology team for the need of hemodialysis. In the meanwhile, the patient was being managed according to the ICU care bundle with continued mobilization, physiotherapy and incentive spirometry. This is the indication of hemodialysis, that is metabolic acidosis, electrolyte abnormalities, fluid overload, uremia, oliguria or drug intoxication. Since no above indication for hemodialysis were present, so nephrology team deferred for dialysis at present. From day 7 to day 10, our patient remained conscious oriented and hemodynamically stable, and lab parameters is starting showing improvement in hemoglobin, platelet and WBC count along with decrease in the creatinine level. We started her on oral feeds which were increased. Patient was mobilized out of bed. We encouraged her incentive spirometry. Patient was shifted to private room and finally discharged on day 11 with the following investigation showing improvement. So the probable diagnosis came out to be purpural sepsis with DIC with query of atypical hemolytic uremic syndrome. Now I would like to call upon Dr. Puneet Pawar sir to summarize the case.
Thank you, Dr. Ayush, for the introduction. Good morning, respected dignitaries and my dear colleagues. I would like to mention why we particularly selected this case for presentation, as this case points out significant challenges. Challenges in this case, firstly, sepsis, as Dr. Yash has already spoken a lot about it. I want to add that clindamycin is essential to halt toxin production and dampen overactivation of immune response, leading to rapid patient recovery. Nextly, coming to invasive versus non-invasive ventilation, we opted for NIV as it is a useful therapy in acute respiratory failure cases with fluid overload. When applied early, its use can improve oxygenation. These guidelines clearly state that the patient with acute pulmonary edema may benefit from continuous positive airway pressure and non-invasive ventilatory support with level 1 evidence. Coming to our next challenge, fluid versus diuretics. As these are exactly opposite therapies, missing them can lead to severe complications. Focus helps us to precisely guide fluid therapy and balance between fluids with risk of overload in sepsis. In sepsis, shock and fluid overload after resuscitation is harmful, hence evacuation is equally important as initial resuscitation. Nextly, the big one, the diagnostic dilemma between DIC and TMA. Dilemma between DIC, HUS and TTP arises because all three conditions present with thrombocytopenia, microangiopathic hemolytic anemia and organ dysfunction. But overlap can occur especially in critically ill patients, making timely diagnosis and initiation of appropriate therapy such as plasma exchange for TTP or supportive care for DIC, a challenging but crucial step. Our take-home message: diagnostic dilemma and overlap syndromes are common in acute and critical care medicine. We should beware of cognitive biases like early closure of diagnosis and anchoring on a single diagnosis. Embrace multidisciplinary perspective when doubt persists. Stabilize, reevaluate, and treat the patient holistically while diagnostic clarity evolves. Treat the patient, not just the reports. On behalf of Department of Critical Care Medicine, I would like to extend my gratitude to our Emeritus Chairperson, Dr. Swankar Sir, and the entire management of MGUMST for their constant motivation and support, to the CCR Review Committee for their rigorous support and helping us prepare the refine this presentation, to all our collaborative departments and to other teams involved in the patient care. Thank you.